Welcome to the June 2021 in-service, dedicated to the wonderful staff of the Kent Northwest Kidney Center. I'm your host today, Andy Brokenbrough, and last month we discussed the negative clinical impact of low blood pressure during dialysis. Today we'll discuss the opposite problem, hypertension among dialysis patients. Hypertension is an even more common problem than hypotension, and it's associated with lots of morbidity and increased mortality. So it's very important that we understand the problem of hypertension during dialysis and have a good idea of how to prevent it and treat it. This talk has three objectives. We will review the epidemiology of hypertension among dialysis patients. We'll discuss the different causes of hypertension, and finally review different treatment options. Let's begin with a discussion of the epidemiology and causes of hypertension among dialysis patients. Hypertension is a very common problem in dialysis patients. How common is it? Well, the prevalence estimates vary widely depending on how you define high blood pressure and also how you measure the blood pressure. And there are lots of different ways that blood pressure can be measured in dialysis patients. We can measure it before dialysis, or we can measure it after dialysis. Patients can measure their blood pressure at home, and we can also do something that we'll discuss later called ambulatory blood pressure monitoring. Based on multiple studies, the prevalence of hypertension among dialysis patients is up to 85% among hemodialysis patients and nearly 30% among peritoneal dialysis patients. In one multi-center trial that included over 2,500 adult hemodialysis patients, the prevalence of hypertension is defined as 1 week average pre-diastolic systolic blood pressure of 150 millimeters or more, or a diastolic blood pressure of greater than 85, or the use of antihypertensive medications was 86%. Hypertension is particularly common among patients who are just starting dialysis. So more than 80% of patients who are just starting dialysis have high blood pressure on the basis of volume overload. This is sort of a theme of today's talk, that persistent hypertension often reflects inadequate volume control despite dialysis, despite blood pressure medicines, etc. Now, there are several different factors that contribute to the high prevalence of hypertension in the dialysis population. The main one that I just alluded to is volume overload. Nearly all dialysis patients are volume overloaded, but they can also have overactivity of their sympathetic nervous system. Certain hormones are present in excess or deficiency, and these can contribute to high blood pressure. And finally, certain medications can raise your blood pressure. By far, the major cause of hypertension in the dialysis population is volume overload. Essentially, if you have too much fluid inside of your blood vessels, it increases the pressure within the blood vessel. And that is why dialysis is such a powerful tool, because it allows us to remove excess sodium and water from the blood vessels and improves blood pressure in the vast majority of dialysis patients. Now, volume overload accounts for the vast majority of hypertension in dialysis patients, but not all of it. There are other causes, including overactivation of the sympathetic nervous system. Now, sympathetic nervous system is part of your autonomic nervous system. It controls things that happen automatically without you thinking about it. So, for example, your heart rate, your digestive system, among other causes. And basically, the sympathetic nervous system is responsible for the body's fight or flight response. So if you happen to be, wandering, say, through the plains of Africa and a lion all of a sudden chases you, your body will instantly produce stress hormones called epinephrine and norepinephrine. These increase your heart rate, they increase how your heart is pumping, and they also cause your blood vessels to tighten up or to vasoconstrict. And all three of these measures will increase your heart rate. And dialysis patients have a lot of reasons to have an overactive sympathetic nervous system. In addition to the overproduction of stress hormones like epinephrine and norepinephrine, other hormones can contribute to high blood pressure in dialysis patients. For example, we have something called the renin-angiotensin system. It's another hormonal system essentially designed to raise blood pressure, particularly in the setting of volume depletion. And this may be responsible, in part, for why blood pressure sometimes rises over the course of dialysis towards the end of the treatment as we remove more fluid and we make their their intravascular system essentially a little bit volume depleted. The renin-angiotensin system can kick in and raise blood pressure to maintain blood supply or perfusion to our organs. The blood vessels in dialysis patients produce vasoactive peptides, which dilate blood vessels, things like nitric oxide, and they are often underproduced in the setting of extensive vascular disease, which is common in dialysis patients. Finally, there is an enzyme that is produced by the kidney called renalase, and that metabolizes catecholamines like epinephrine and norepinephrine. And so if you don't have good kidney function, you don't make as much of this renalase, and so you have too much catecholamine, too much epinephrine and norepinephrine in your circulation, which will raise your blood pressure. Medications can also raise your blood pressure. In fact, erythropoiesis stimulating agents such as Aranesp or Mircera are thought to raise blood pressure to a certain degree. Over-the-counter medications such as nasal decongestants, as well as non-steroidal anti-inflammatory drugs such as ibuprofen, Aleve, Motrin, Naproxen, these can also raise your blood pressure. And finally, illicit drug use, basically stimulants such as cocaine and methamphetamines, of course, can also raise your blood pressure. Okay, let's now discuss the diagnosis of hypertension as well as its monitoring in the dialysis population. Now, the actual diagnosis of hypertension among the dialysis population is more complicated than you would think. Should it be based on pre-dialysis blood pressures or post-dialysis blood pressures or the average blood pressure over the course of dialysis treatment, or should it be based on home blood pressure readings, etc.? The lack of a standard definition of hypertension does confuse interpretation of the literature. In the literature, the gold standard for diagnosing hypertension among the dialysis population is something called ambulatory blood pressure monitoring. This involves measuring the blood pressure frequently, say every 30 minutes or so over a 24-hour period, or sometimes we do it for 44 hours, the time in between a dialysis session. How is it done? Well, basically, you take a really small digital blood pressure monitor and you attach it to the patient's belt, and then you put a small cuff around their upper arm. And it's small enough that it's not thought to significantly affect your normal daily life or your ability to sleep. There are several advantages to ambulatory blood pressure monitoring. It's, again, considered the gold standard for diagnosis of hypertension. You get multiple values over a long period of time, gives you more data points. It provides reproducible readings, and these actually correlate with clinical outcomes in dialysis patients. The problem is it is generally not used clinically because it's a little bit cumbersome to do. Patients don't want this thing strapped to their arm. It's not widely available. So in theory, it is a wonderful way to diagnose high blood pressure, but it's something that we don't typically use in the dialysis population. An alternative to ambulatory blood pressure monitoring in the dialysis population is just simple home blood pressure management. Patients can measure their own blood pressure at home, and they can bring a record to the nephrologist or to the dialysis unit. The optimal frequency of monitoring is not known. Do you check it every day? Do you check it twice a day? Do you check it in the morning? Do you check it in the evening? But it offers several advantages. I mean, it's very efficient, it's inexpensive, it's pretty accurate, and the values that you get at home correlate pretty well with ambulatory blood pressure monitoring as well as with clinical outcomes. Um, I guess the disadvantage is, sometimes it's hard to get patients to measure their blood pressure, and you ask them what their blood pressure is. Invariably, they always say it's 120/80. So sometimes you don't always get them to do it, but if they are willing to do it, it provides very useful information. As I just mentioned, one of the main advantages of home blood pressure measurement is that measurements correlate with clinical outcomes. So your blood pressure at home predicts how you are going to do from a cardiovascular standpoint in the long run. This is an observational study published in 2015 that looked at 326 incident dialysis patients. So these were new to dialysis, and what they found that was a single recording of their systolic blood pressure measured outside the dialysis unit was directly related to their mortality for every 10 millimeters of blood pressure increase. So for example, if you had a systolic blood pressure of 150, your mortality was 26% higher than someone who had a blood pressure of 140. If you had a systolic blood pressure of 160, your mortality was 52% higher than someone who had a blood pressure of 140. In contrast, blood pressure measurements before and after dialysis are not great for diagnosing hypertension or titrating blood pressure medication. They only correlate weakly with ambulatory blood pressure monitoring or home blood pressure measurements, and they don't predict clinical outcomes very well. The pre-dialysis blood pressure readings tend to overestimate home blood pressure. The post-dialysis blood pressures tend to underestimate the home blood pressure readings. But in fact, the values are all over the place. So this is a study published by Agarwal in 2006. It was a meta-analysis of all the studies comparing ambulatory blood pressure monitoring with pre- and post-dialysis blood pressure measurement. And what they found was compared to a 44-hour ambulatory blood pressure monitor. So basically checking blood pressure in the interdialytic interval between two dialysis sessions. That pre-dialysis systolic blood pressure ranged from anywhere from 42 millimeters of mercury higher or 25 millimeters of mercury lower than the ambulatory blood pressure monitorings. And the post-systolic blood pressures range from anywhere from 33 millimeters of mercury higher to 36 millimeters of mercury lower. So they're really all over the place, don't correlate well with the ambulatory blood pressure monitoring, which again is the gold standard. So why in the world do we bother to measure blood pressure during dialysis if they don't predict clinical outcomes and they don't correlate well with someone's average blood pressure during the interdialytic period? We do it for one reason, to assess the hemodynamic stability of the patient during treatment. So we are not doing it to measure their blood pressure or to estimate their blood pressure control. It's really for safety reasons during the blood pressure treatment. Let's now discuss the benefits of treating blood pressure in the dialysis population. There are multiple studies and multiple meta-analyses of randomized controlled trials in dialysis patients that have suggested a benefit of using antihypertensive agents to lower blood pressure with respect to cardiovascular events and cardiovascular mortality. One such study is a meta-analysis of 8 randomized controlled trials published in The Lancet in 2009, included almost 1,700 dialysis patients, and what they found that lowering blood pressure with antihypertensive therapy was associated with reduced risks of cardiovascular events, all-cause mortality, and cardiovascular mortality. Another one of these studies by Agarwal in 2009 was a meta-analysis including 5 randomized trials of 1,200 hemodialysis patients. Compared with placebo or control therapy, blood pressure lowering with antihypertensive therapy resulted in a 31% reduction in the risk of cardiovascular events. This is about the same magnitude as the study that we just saw by Hirspink, also published in 2009. So we know that hypertension increases cardiovascular mortality and that treatment of hypertension in the dialysis population reduces cardiovascular complications. So what's the ideal blood pressure target in dialysis patients? Unfortunately, it's not well established. We do know, as I mentioned earlier, that home blood pressure readings correlate with clinical outcomes, unlike in-center blood pressure readings. But there are no large-scale trials that define optimal self-measured home blood pressure targets among dialysis patients. Based on smaller studies, however, we have derived the following consensus opinions. First, blood pressure treatment should not be based on your pre-dialysis systolic blood pressure. It's tempting to do that, but it doesn't translate into better clinical outcomes. Second, some people use the midweek blood pressure, which is calculated essentially from all the blood pressures measured during a midweek dialysis session, say on a Wednesday for a Monday, Wednesday, Friday patient, or on a Thursday for a Tuesday, Thursday, Saturday patient. And ideally, you want the blood pressure below 140/90 on average. Or if you're using home blood pressure measurements, again, a blood pressure less than 140/90 is the recommended opinion. It's not based on data, it's just based on consensus opinion. There was an interesting observational study published by Alborzi in 2007. It involved 150 dialysis patients who were followed for a median of 2 years. At the start of the study, blood pressure was recorded by one of three methods: pre and post dialysis, or by a 44-hour ambulatory blood pressure monitoring during the midweek interdialytic interval, or by home blood pressure self-measurement over a 1-week period. And what they found was that blood pressures obtained by home and by ambulatory monitoring were associated with mortality. So they were good predictors of their long-term mortality. And interestingly, the patients who had a blood pressure between 115 to 125 had lower mortality than those who had home blood pressure between 125 and 145, suggesting that lower blood pressure decreases mortality in dialysis patients. But you have to be cautious when interpreting observational data, which is good for establishing associations between a predictor of interest, such as blood pressure, and an outcome variable, such as mortality. Just because dialysis patients with systolic blood pressures that are lower seem to have better clinical outcomes in the long run doesn't mean necessarily that lowering blood pressure to this range will necessarily translate into better clinical outcomes. For example, this is a study by Miskulin in 2018. It was a randomized controlled trial of 126 hypertensive hemodialysis patients. Randomized them to either a pre-diastolic systolic blood pressure of 110 to 140 or a pre-diastolic systolic blood pressure of 155 to 165. Turns out that the intensive arm actually had a higher risk of recurrent hospitalization, vascular access thrombosis, and intradialytic hypotension. In fact, multiple large observational studies have demonstrated what we call a U-shaped relationship between pre-dialysis and post-dialysis blood pressure and mortality among dialysis patients. The U-shaped relationship, which I'll show you in a second, suggests that both low and high blood pressures are associated with increased mortality compared to people with blood pressure in the mid-range. So for example, this is an observational study of over 9,000 hemodialysis patients in France who were followed prospectively for a median of 548 days. People who had the lowest mortality had a pre-diastolic systolic blood pressure of around 150 millimeters of mercury, and mortality actually increased if blood pressure was below that, or increased if blood pressure was above. Let's now talk about therapeutic options for controlling blood pressure in the dialysis population. There are several ways we can lower blood pressure. We can optimize their dry weight or their target weight. We can encourage them to follow a low sodium diet. We can reduce the amount of sodium in their dialysate. And of course, we can put them on blood pressure medication. So recall sodium and water balance in dialysis patients. So normally the body gets rid of sodium in the urine, but if you have kidney failure, sodium is retained in the body. This increases the sodium concentration in the blood and triggers thirst, and that makes you drink water. This leads to salt and water retention. If you have too much salt and water in your blood vessels, then you have high blood pressure. If you have too much salt and water in your tissues, then you have edema. Fun fact, for every 9 grams of sodium chloride that you consume, the sodium concentration of the blood increases and stimulates thirst enough to drink 1 liter of water. The clinical consequence of consuming too much salt, if you're a dialysis patient, is the retention of water, and people present with large fluid gains, and we can't take off all that fluid during a dialysis session, so they don't achieve their prescribed dry weight. They're chronically volume overloaded, chronically hypertensive. So what is dry weight? Well, it's been variably defined, but one definition is it's the body weight at the end of dialysis at which the patient can remain normotensive, so have a normal blood pressure until the next day without antihypertensive medication. So it's the ideal post-dialysis weight that allows for a normal blood pressure. So if you want to control blood pressure in a dialysis patient, you have to optimize their dry weight or their target weight. Now, if achieving the dry weight is difficult, consider increasing dialysis time or the frequency of sessions. We have lots of data and lots of historical evidence that this is a very effective way to control blood pressure. As many of you know, chronic dialysis was pioneered in Seattle. And back then, patients, if they did in-center dialysis, they dialyzed for 20 to 40 hours per week. And the vast majority of these patients needed no blood pressure medications. Similarly, back then they would do home dialysis and they would dialyze for 8 to 10 hours thrice weekly at home, so between 24 and 30 hours of dialysis. And the vast majority of these patients also required no antihypertensive medications. So we definitely can control blood pressure in the dialysis population with volume control. It's very important that our patients follow a low-salt diet. If they don't eat salt, then they won't be thirsty and then they won't gain a lot of fluid in between dialysis treatments. The goal is to consume less than 2 grams of salt per day. Less salt consumption leads to less fluid gain, leads to lower blood pressure, and because we're not taking off so much fluid, we have less intradialytic hypotension. Another tool for controlling blood pressure and volume overload in dialysis patients is reduction in dialysate sodium concentration. So if we dialyze a patient with a high dialysate sodium concentration, for example 140 millimoles per liter, then sodium actually diffuses from the dialysate into the patient's blood. It leaves the patient with a net sodium balance, so a positive sodium balance. So they leave dialysis actually with more sodium in their blood, and that makes them thirsty, and then they drink a lot of fluid, and they come in volume overloaded. In contrast, if we use a lower dialysate sodium concentration, for example of 136 millimoles per liter, this actually removes salt from the patient, so sodium diffuses from the blood into the dialysate and then down the drain, and this lowers blood pressure, and they leave the dialysis unit with less sodium in their blood, and they are less thirsty. This is a small study published in 1998 by Krauting. It was a non-randomized intervention trial of 8 hypertensive hemodialysis patients who were dialyzed against a gradually decreasing sodium dialysate concentration. So start out at 140, and over the course of several weeks, they reduced it to 135. And of course, patients were encouraged to limit their sodium intake to less than 6 grams per day, which is actually a very generous allowance of sodium for a dialysis patient. We encourage less than 2 grams. At the end of the study, the mean arterial pressure was lower, and in 4 of the 8 patients, antihypertensive medications were stopped. So again, if you control sodium intake and removal more efficiently, then you can definitely improve their blood pressure control. Of course, it was difficult for the patients to adhere to the diet, and there was more cramping during dialysate with the low dialysate sodium concentration. Despite the fact that we can control blood pressure with the vast majority of dialysis patients with just better sodium control, these days over 80% of hemodialysis patients use blood pressure medications. In general, we really try to control someone's volume status first before adding antihypertensive medications, but so many dialysis patients start dialysis on 3 or 4 blood pressure medications and they never seem to get stopped. It's worth mentioning that some antihypertensives are removed by dialysis and others not, and this may explain why blood pressure can sometimes rise over the course of the dialysis procedure as we remove their blood pressure medications. Commonly dialysable antihypertensives include lisinopril, enalapril, the beta blockers atenolol and metoprolol. In contrast, many medicines are not removed with dialysis. These include the angiotensin receptor blockers such as losartan. Certain beta blockers like labetalol and carvedilol are not dialysable. And finally, the calcium channel blocker amlodipine is not removed with dialysis. In general, I like to use medications that are not removed by dialysis because I don't like to see their blood pressure rise over the course of the treatment. As I mentioned before, if possible, you really should establish their optimal target weight before adding on antihypertensive medications. But again, so many patients are on blood pressure medications when they start maintenance dialysis. And this can be a downside because it can limit the amount of fluid that we can actually remove as a consequence of interdialytic hypertension. I mean, if they're on blood pressure medications and we're removing fluid, they're much more likely to have a low blood pressure during treatment. Some dialysis patients have what we call resistant hypertension. No matter what we do, their blood pressure always remains high. Some possible causes include non-adherence to their antihypertensive regimen or to a low sodium diet. Concurrent use of medications that can raise blood pressure. Again, non-steroidals can do it. Epogen like Mircera can do it. Inadequate dialysis. Basically, some people just need more dialysis or longer dialysis sessions to achieve optimal blood pressure control. There's something called renovascular hypertension. A lot of dialysis patients have significant vascular disease. And if you have a narrowing of the blood vessel that supplies the kidney, then the kidneys, even if they're only working at 5%, can produce hormones that will raise blood pressure in an effort to try to deliver more blood supply to the kidneys. And we have a bunch of patients with polycystic kidney disease. It's thought that the expanding cyst can sometimes compress blood vessels within the kidney. That also can trigger the release of hormones that raise blood pressure. Interestingly, some patients develop paradoxical hypertension in the later stages of dialysis. So again, in the third or fourth hour, their blood pressure rises. And there's some observational evidence to suggest that this does not portend a good long-term clinical outcome. Different mechanisms for this, it could be hormonal. Again, for example, if you remove a little bit too much fluid with dialysis, then you can activate certain hormonal systems such as the renin-angiotensin system, which raises blood pressure. Another potential cause is the removal of blood pressure medications. And then finally, just persistent volume overload if we're not taking off enough fluid. Better volume control also seems to be fairly effective for dealing with patients who develop blood pressure over the course of their treatment. This is a randomized crossover trial of 16 hemodialysis patients with intradialytic hypertension. So in other words, their blood pressure started out good at the beginning of dialysis and rose over the course of the treatment. And what they found was that if they dialyzed patients with a high dialysate sodium, their blood pressure was really high. If they use a low dialysate sodium, their blood pressure control improved. Again, suggesting that this is in part a volume-mediated process. In summary, hypertension is a very common problem among dialysis patients. In some studies, greater than 80% prevalence. The optimal blood pressure target is unknown. Home blood pressure readings correlate well with long-term clinical outcomes, whereas in-center blood pressure readings do not. There's limited interventional data to suggest that lowering blood pressure in dialysis patients can be associated with worsening clinical outcomes, increased hospitalization, increased mortality, increase of access thrombosis. Many commonly used antihypertensive medications are removed during the dialysis procedure, and these include lisinopril, enalapril, atenolol, and metoprolol. We have several interventions available to us to lower blood pressure, including reducing dry weight, reducing dialysate sodium, encouraging a low sodium diet, as well as recommending longer dialysis or more frequent dialysis. Finally, if a patient has refractory hypertension or their blood pressure rises during the dialysis procedure, consider non-compliance with medications or diet, persistent volume overload, or dialysability of their blood pressure medications. All right, everyone, it's time for the quiz. So how common is hypertension in the dialysis population? You got it. Prevalence estimates vary depending on how it's defined, but based on multiple studies, up to 85% of hemodialysis patients and about 30% of peritoneal dialysis patients are hypertensive. Question number 2. What is the most common cause of hypertension in the dialysis population? That's right. Volume overload. Fantastic. Next question. What blood pressure readings correlate best with clinical outcomes? Excellent. Home blood pressure readings. So again, home blood pressure readings, whether it's done by single measurements by the patient or ambulatory blood pressure monitoring, correlate well with clinical outcomes, whereas in-center readings do not. What are therapeutic options to lower blood pressure in dialysis patients? Fantastic. Basically all of the above. So reduced dry weight, reduced dialysate sodium concentration, blood pressure medications, and the one that I didn't put here or add on is a low salt diet. Next question, name 3 causes of difficult to control hypertension among dialysis patients. Very good. So non-adherence to blood pressure medications or diet, the use of medications that can raise blood pressure, inadequate dialysis, or renovascular hypertension. This concludes the Kent-In service for the month of June 2021. Thank you for your attention and service to the best dialysis unit in the Western Hemisphere and probably the world. We'll see you next month.